Sir, we are live. Over to you. Please start. Sorry for delay.
Thank you, Ankur. Thank you. Yes, shall we start, sir?
Yeah. Okay.
Yeah. Thanks, sir. Good evening, doctors. On behalf of Alchem Laboratories, India's fifth largest pharmaceutical company, I am Balaji of Alchem Aspiria Division. Take great pleasure in welcoming all the eminent doctors who have joined us for today's panel discussion. Doctor, today's panel discussion will be on vildagliptin, titled Views on Vildagliptin. Doctor, at Alchem, it has always been our endeavor to partner with healthcare professionals, and we will continue to do so even in these challenging times. To navigate through the entire meeting, we have with us today Senior Consultant Diabetologist, Dr. Mahesh Babu sir, who will be our moderator for today's panel discussion. Welcome, Mahesh Babu sir, for today's panel discussion.
Thank you.
Take this opportunity to give a short introduction about our moderator, Dr. Mahesh Babu sir. Dr. Mahesh Babu sir is a Senior Consultant Diabetologist who is practicing at Madurai. Doctor is associated with Meenakshi Mission Hospital and Research Center, Madurai. Doctor has completed his undergraduation in the year 2003 at Madurai Medical College and diploma in diabetology in the year 2006 from Madras Medical College, and he has undergone his post-graduation in the year 2011 at Madurai Medical College. Doctor's key interest is at intensive care.
We can skip the introduction and go to the program.
Right. Okay. I'll give probably short introduction. Thanks. Let me take this opportunity to welcome all the eminent panelists who have joined us for this panel discussion. Let me take this opportunity to first welcome the senior panelist, Dr. Sampath Kumar sir. Dr. Sampath Kumar sir, senior consultant and nephrologist who is currently practicing at Meenakshi Mission Hospital, Madurai. Welcome, sir, for this panel discussion. Let me take this opportunity to welcome the next panelist, Dr. Joseph Panneerselvam sir. Joseph Panneerselvam sir is a senior consultant diabetologist who is practicing at Trichy. Doctor is associated with Maruti Medical Center, Trichy. Welcome, Joseph sir, for this panel discussion. We have with us Dr. Shivakumar sir. Dr. Shivakumar sir is a senior consultant physician and diabetologist who is practicing at Rajapalayam. We have Dr. Shivakumar sir as one of the panelists. Welcome, Shivakumar sir, for this panel discussion. We will be having Dr. Balamurugan sir. Dr. M.L. Balamurugan sir, who is a senior consultant physician and diabetologist who is associated with Trichy Diabetes Specialty Center. He'll be one of the panelists. He'll be joining in a couple of minutes. And we'll be also having Dr. Sundaramurthy sir, consultant cardiologist and diabetologist who is practicing at Dindigul. He'll be joining in a few minutes. So he'll be one of the panelists. So with this panelists, we'll start our meeting. So with this short introduction of panelists, let me hand over the session to moderator. Sir Mahesh Babu sir, over to you, sir. You can set the context for the meeting.
Thank you, Balaji, for the kind introduction. So, good evening to all. At the outset, I'd like to thank Alchem for this opportunity to invite me as a moderator for this program. So, as we all know that after the introduction of DPP-4 into the field of diabetes drug armamentarium, the treatment style itself changed. So, we got a new drug without hypoglycemia and a weight neutral agent. So, till the introduction of DPP-4 inhibitors, we had sulfonylureas, metformin with a lot of adverse events like hypoglycemia and weight gain. After the introduction of this new agent, that is the DPP-4 inhibitor, which is just going to prolong the half-life of endogenous GLP-1, which is secreted from the intestines. Anyhow, it is again going to act as an insulin secretagogue. This GLP-1 has an effect on alpha cells as well as beta cells. So it is acting in a glucose-dependent manner to release the insulin. Only when the glucose is there, this GLP-1 is going to act on the beta cells to release insulin. So in that manner, this has revolutionized the treatment of diabetes, and a lot of hypoglycemia has been avoided after the introduction of these agents. So today's panel discussion, there will not be any slide presentation. It is just going to be a panel discussion with all experts. So all the 5 doctors are experts in their own fields, and we will be getting opinion from each and every one of them. So today we will be starting with Dr. Sambat Kumar sir. So he has another meeting at 8:30. So after his opinion about vildagliptin, we will be moving on to other consultants. So Dr. Sambat Kumar sir, we would like to know about the role of vildagliptin combinations in your patients, particularly patients with the diabetes and CKD, and diabetes and elderly people with CKD.
Thank you, Dr. Magesh Babu. Thank you for this opportunity. As you have correctly said, there has been a paradigm shift in the way that we manage diabetes over the last 10 years. There has been a tremendous increase in the number of molecules which have really rushed into the field, and we are now having plenty at our hands. So now the question arises as to how to go about adding or subtracting a molecule in patients with renal disease. The first aspect which I look is that more advanced the renal disease, more chances of hypoglycemia. So you are going to play safe. So safety first will be the first principle of a nephrologist when he introduces or when he chooses a molecule. On that score, DPP-4 inhibitor has been my first choice. Vildagliptin has been found to be very useful in my patients. The dose that I use when the GFR is less than 25 ml per minute is only 50 milligrams, which is again welcome in the field of economics of the patient, because he has to spend less on a tablet. So on that score also, vildagliptin scores over the other DPP-4 inhibitors, where the same dose is being used even in stages of severe renal failure. For example, linagliptin requires the same dose. Then the other aspect of vildagliptin, which is found to be useful in my practice, is that even though large scale studies, just like how SGLT2 inhibitors have been studied in diabetic nephropathy, are not available in DPP-4 inhibitors, especially vildagliptin. What we have observed is that the worsening of the proteinuria is halted, and also the reduction in GFR, which is very, very rapid in diabetic nephropathy, especially in Indian patients, is 50% halted. What we observe in our studies or in our day-to-day practice is that once the GFR comes below 50 ml per minute, every year he loses as high as 10 ml per minute, which is not the case in the Caucasian population. So there is a tremendous drop of GFR, so that within 5 years from 50, he comes to a GFR of 0. So this very advanced, very rapid progression of diabetic renal disease is seen in Indian population. So a drug like DPP-4 inhibitors will be very useful, not to halt it from 50 to say from 5, but to some extent it will reduce the GFR loss from a 10 ml per year to 2 or 3 ml per minute per year, which is again you are gaining 3 to 4 years of dialysis free life, which is very substantial. On that score, I am very happy. When you come to the pharmacokinetics of this molecule, it has got a large excretion by the kidneys. So more than 85% is excreted by the kidneys. So there is definitely going to be an increase in the half-life. The normal half-life of 3 hours is going to get increased when there is a low GFR. So you can reduce the dose, and the side effect profile is very patient friendly. The only side effect profile which I have found is that to some extent it reduces the gastric emptying, and this could be not very welcome in diabetic patients. So if in some patients who are prone for the gastroparesis of diabetes, you may have to stay away from this molecule. Otherwise, almost all the plus points of oral hypoglycemic agents, without the minus points of sulfonylurea and metformin, I can use this molecule. Thank you.
Yes, sir. Your point is well taken regarding the gastroparesis. These are drugs which are going to prolong the endogenous GLP-1 action. So GLP-1 has an effect on this gastric emptying. So we use it as one of the mechanism by which glucose comes down in patients who have uncontrolled diabetes. But particularly in patients which you see, like patients who have high level of creatinine, because of the nausea
Yes.
and uremic symptoms, these could be a side effect in those patients. Rather than being an effect, it could be a side effect in your type of patients. And one more question to you, sir. Do
Yeah.
you see any difference between the gliptins in your usage?
No, I don't find a great difference. Almost all the gliptins that I have been using, I find that all of them are equally efficacious and equally without any side effects.
Okay. And one more question, sir. Do you
Yeah.
find extra benefit when you combine SGLT2 inhibitors with DPP4 inhibitors in your patients?
I do find that the blood pressure reduction seems to be slightly more when I add DPP4 inhibitors with the SGLT2 inhibitors. I just went through the literature and found that to some extent the vascular toxicity of the diabetes is also negated by DPP4 inhibitor. And so that could be one reason why I find that the blood pressure reduction, even to some extent, some of them go into slightly hypotensive role, because there could be some natriuresis also with the DPP4 inhibitors. When you add it to the glycosuria, this is another effect that I am seeing.
Okay, sir. Do you find reductions in the adverse events like mycotic infections and UTI when you combine these two agents, sir?
Urinary tract infections, I am not able to give you an answer, but theoretically, it seems to be a beneficial action. And when you have a patient with a recurrent urinary tract infection, I would rather go for a DPP4 inhibitor rather than a SGLT2 inhibitor. So, in patients who are having early episodes of UTI, cystitis, pyelonephritis, I would rather go for this drug. Even though SGLT2 inhibitors, they say that you can still use it, I am not very much convinced. I would rather go for DPP4 inhibitors.
Okay, sir. One final question to you, sir. What is your take on once daily preparation of vildagliptin?
It should be good, because whenever you are able to have a once daily regimen, the compliance is going to be better. And if they are able to ensure that the delayed release is able to provide the 24-hour protection, this will be very welcome.
Okay, sir. Thank you, sir. We
Thank
will
you.
move
Thank
on
you.
to the next topic now.
Yeah.
So we will now move on to the topic proper with respect to vildagliptin, that is the Verify trial. So this Verify trial is a unique trial, first of its kind, to find out whether the combination therapy in type 2 diabetes is better than starting with metformin alone. Most of the global guidelines like ADA or EASD and also the Indian guidelines from the RSSDA suggest us to start with metformin for all newly detected type 2 diabetes. But this Verify trial has been done with a combination of metformin and vildagliptin as an initial therapy for all newly detected diabetes on one side, and on other arm, the patients were treated conventionally with metformin. And the results were very good, that the failure rate in those patients who were started on combination therapy were very less. That is, they were able to maintain the HbA1c for a long duration of time without any uptitration than when compared with that of metformin. So let me get the opinion from Dr. Joseph Panniselvam regarding this Verify trial. Sir, over to you, sir.
Thank you, Mahesh. Yeah, it's a combination therapy. It's not a new one. So when we combine different groups of drugs, the different mechanism of action, naturally, so we can target multiple pathophysiological mechanisms. So regarding the guidelines, international guidelines, all the guidelines they suggest metformin is the first line drug. But we in our clinical practice we see most often metformin may not be sufficient after some time. So the patient glycemic control again, so the blood sugar levels and HbA1c, we are not able to achieve the required HbA1c reduction. So naturally, so the combination therapy is better. So in this trial, so they have included only the newly diagnosed diabetic patients. So the HbA1c of 6.5, between 6.5 to 7.5, with very good results, because the if we achieve we are able to achieve the good glycemic control early in the course of diabetes, so we can avoid the future complications of diabetes. So it's a legacy effect. So it's a very good option. So when we combine metformin with the vildagliptin, so the treatment failure also based on this trial. So they say that the chances of failure, first failure and second failure, are very less. And this combination is very well tolerated. So we see in our clinical practice, so it's one of the very good, very well tolerated combination without much side effects. So so we are able to achieve the glycemic control also with the less side effects, like especially when we use sulfonylureas. So that is a very big problem. It's a nightmare for the patient. So once the patient develops hypoglycemia, so they'll be afraid of taking medications. So this problem will not be there when we combine this, when we use this combination hypoglycemia. The another advantage is weight gain. So there's no weight gain in this combination. So it's ultimately is going to be beneficial for the patient, because the patient, most of the patients, when we use sulfonylureas and insulin, they'll put on weight. It will become a problem. So the way we can avoid weight gain also. So these are all the advantages. So definitely this is a very good combination. We can start. We can use this combination for newly diagnosed diabetic patients.
Yeah, your point is well taken, sir. Dr. Balamurugan, sir, what is your idea on Verify trial? Balaji, has Balamurugan sir joined?
Sir, Dr. Balamurugan sir had some medical emergency.
Okay. Then we will move on. So the idea of Verify trial is nothing but early and intensive treatment in diabetes. So this we have been practicing for a long duration of time. Even since I started my practice, I have been giving dual drug combination for many of my newly detected diabetes, and we have found good results. But now we have evidence to support our clinical practice. So early and intensive therapy, as told by Dr. Joseph, is going to impart a good effect, that is good glycemic legacy, on those patients who are on intensive treatment after even 10 years of their diabetic life. This has been proved from various trials like UKPDS trial and VADT trial, where even after 10 years of diabetes, those patients who are kept on intensive treatment had less number of complications. So we have to start using early combination in newly detected diabetes. So guidelines may be there. Guidelines always, they are for newcomers or new doctors who are learning. But as experienced physicians, we have to start imparting our own views and own practice in clinic. So moving on to the next topic, vildagliptin is being available with various combinations, like vildagliptin with metformin is available, vildagliptin with SGLT2 inhibitors are available. I would like to get the opinion from Dr. Sivakumar sir with respect to this combination therapies in diabetes.
Thank you, sir. Vildagliptin with SGLT2 inhibitors, they are both synergistic in action. So it is always better to, in Indian set of patients, it is always better to combine two drugs so that patients' compliance and adherence will be better. So that since lot of trials like DCCT, UKPDS, all these things showed that the HbA1c reduction is very, very important in achieving or in avoiding long-term complications. So to avoid long-term complications and to make HbA1c very good tight control, we have to give a lot of drugs in these diabetic patients. So the patient's adherence will be very poor. So combining these drugs, the adherence and compliance will be very good. But we have been using a lot of metformin with the glimepiride till now. The main drawback of these drug is hypoglycemia and weight gain. So there are a lot of patients coming to back us with hypoglycemia and weight gain because of this sulfonylureas. So we are entire community, medical community, is searching for a drug which is weight neutral and which is not having hypoglycemia and also having a good HbA1c reduction. So at this time, this DPP4 inhibitors came into vogue, and the incretin effect was identified, and this DPP4 inhibitors came into vogue. And this DPP4 inhibitors and SGL2 inhibitors, there are a lot of combinations, and these two act synergistically to reduce the HbA1c. And recently, this endogenous glucose output, glucose production is very high in those patients, those subset of patients who are treating only with the SGL2 inhibitors because of glycosuria. So this DPP4 inhibitors counteract that, and so by combining with SGL2 and the DPP4, we can target the HbA1c to be very low and avoiding future complications. And also vildagliptin or any other gliptin, especially vildagliptin with metformin, is a very good combination because of a lot of things are happening here. The metformin is weight reduction, weight reducing drug. Vildagliptin is weight neutral, and hypoglycemia is very, very low in this combination. And also the HbA1c rate is very HbA1c reduction is very good. So by looking all these things, definitely combination therapy either with the metformin or with the SGL2 inhibitors along with the vildagliptin definitely will score over individual therapy in achieving HbA1c control and avoiding long-term complications. Thank you, sir.
Good, sir. Your point is well taken, because you have highlighted the points that whenever we choose a oral anti-diabetic agent, that is ideal anti-diabetic agent, should be efficacious, the first point. The second point should be it should not produce hypoglycemia, and the third one, it should not produce any extra weight gain. So all these 3 points are satisfied by using this combination of vildagliptin and metformin. So I used to call DPP4 inhibitors as smart molecules because they have action on both alpha cells as well as beta cells. So as I told earlier, they are coming under the category of glucose dependent insulin releasing molecules. So only when the glucose levels are high, it is going to act on the beta cells to release insulin, and on the other hand, it will suppress the alpha cells and it will reduce the glucagon secretion. On the contrary, when the patient has very low blood sugar levels, the opposite thing is going to happen. That is, they preferentially stimulate the alpha cells and suppress the beta cell insulin secretion so that the patient does not go for severe hypoglycemia. So that's the reason we combine these DPP4 inhibitors with insulin also. When you combine these agents with insulin, the risk of hypoglycemia comes down to a great extent because of this effect on alpha cells. So moving on to Dr. Sundaramardu. So, sir, what is your view on vildagliptin and its combination, particularly vildagliptin plus SGLT2 inhibitors and vildagliptin plus metformin in cardiac patients? So kindly unmute, sir.
Yes, sir. Good evening, one and all. Most of the times when the diabetic patient comes to us, the monotherapy will not be sufficient to control most of the time because already they are in third year or fourth year only, they are coming for treatment most of the time. At the time, definitely there is a need for combination therapy. Previously, there is very restricted molecules are available. Nowadays, there is a wide molecules are available. As particular to cardiac and diabetic, the combination with sulfonylureas are previously available, but sulfonylureas were not cardiac friendly. So next to that, combinations of DPP4 and SGLT as recent molecules available for combination therapy. In this combination, as pertain to cardiac, if the patient already have established cardiac problem also, then the preferred combination is metformin plus SGLT2 inhibitor. But most of the studies proved the positive effects of SGLT2 inhibitor. Whereas according to the DPP4 inhibitor, they are cardiac neutral most of the time. There is not a very positive benefit, that is a reduction in MI or reduction in cardiac failure or improvement in LV function, are not noted in this DPP4 inhibitor, especially in vildagliptin. At the same time, the side effects are also not high. There is no increase in MACE, cardiac events, or increase the worsening of heart failure, are not also noted in majority of studies. So as a cardiac patient with a diabetic, the first preferred combination is the metformin plus SGLT inhibitor. If some reasons the SGLT are not available or are not adequate to control blood sugar, then the other choice is we can add vildagliptin along with SGLT inhibitor, metformin, and zinc and insulin are always there to control sugar. This is the cardiac view of combinations.
Yeah, okay, sir. Your point is well taken. As you told, all the gliptins are neutral with respect to cardiovascular effects. So almost all the gliptins have undergone their own cardiovascular outcome trial except vildagliptin. So all other gliptins have proved that they are safe with respect to cardiovascular patients. And the important reason behind vildagliptin not undergoing CVOT trials are that even in the preliminary trials itself, they showed that they are cardiovascular safe. So the FDA did not mandate the innovator company to undergo a CVOT. So that's the main reason for which vildagliptin does not have any individual dedicated randomized control CVOT trial. So that itself means that it is cardiovascular safe. But on the whole, when we talk about DPP4 inhibitors and cardiovascular disease, we should be very careful with respect to the stage 3 and stage 4 cardiac failure, because some of the drugs like saxagliptin and alogliptin in their cardiovascular outcome trial has found to increase the number of admissions for heart failure in those patients who are treated with the particular agent when compared to placebo. So after these outcome from the cardiovascular outcome trials, the FDA has given a clear black box labeling that all the DPP4 inhibitors should be very carefully used in patients who have stage 3 and stage 4 cardiac failure. Whereas in stage 1 and stage 2, you can use, but you have to keep an eye on the ejection fraction and you have to frequently monitor for the cardiac failure symptoms. So if there are symptoms of cardiac failure which is getting aggravated, you need to stop these DPP4 inhibitors. So they are very clear. For stage 3 and stage 4, don't use DPP4 inhibitors. But as of but for cardiac failure, other aspects of cardiovascular disease, DPP4 inhibitors are very neutral. So the next topic is regarding CKD, which Sampath Kumar sir has clearly described. And moving on to the next topic, the use of vildagliptin in elderly patients. So elderly patients, by definition, we mean after 70 years. So far, before the advent of DPP4 inhibitors, we had very difficult time in treating these patients because of increased risk of hypoglycemia with sulfonylureas and other agents like insulin. But after the advent of DPP4 inhibitors, we are very safely using vildagliptin and other gliptins in elderly patients. So what is your idea regarding this use of vildagliptin in elderly patients, sir? Dr. Joseph, sir?
Yeah, the elderly patients, they are coming in a very special group because they will be having multiple comorbidities. So there's a chance of polypharmacy. So that will increase the side effects profile. So when we use this DPP4 inhibitors, so we can avoid the side effects, mainly side effects, because it's very well tolerated. So the durability, so the trials have proven that, so it has got durable action over the period, even after 5 years or even 10 years. So patients are responding. So the durability is there. Without the fear of hypoglycemia. So the hypoglycemia is a very important concern in the elderly patients, because so they may not be able to identify, because so hypoglycemia unawareness may be present in elderly patients. So they may not be able to identify hypoglycemia. That will be very dangerous. So in such scenario, this vildagliptin will be very, very useful combination, so that we can use it without any fear of weight gain or hypoglycemia. So most of the patients, they are it's very well tolerated. The patients' tolerability issues not there, not much side effects. So some of the patients, they complained of decreased appetite. So it's a main complaint from the patients, those who are taking vildagliptin. So the appetite will be decreased. So that's a concern. Otherwise, it's a very well tolerated in elderly diabetic patients.
Yeah, what is your review, sir, Dr. Sivakumar, sir, with respect
sir.
to elderly patients?
Yes, sir, I fully agree with Dr. Joseph sir views, because we have already sir told there will be a lot of drugs the patients will be taking for other comorbid conditions like heart failure, hypertension, and osteoporosis and prostatic hypertrophy. A lot of things they will be taking. So, and we have to avoid at any cost. We have to avoid even one single episode of hypoglycemia in these elderly patients because of risk of fall and another going for other complications. So it should be weight neutral, and so we have to avoid sulfonylureas. So next better drug is gliptins. So we in elderly patients, actually gliptins is boon to them. So we should add, if no contraindication exists for elderly patients who are not controlled with one drug, we should add vildagliptin rather than sulfonylureas without any, if there is no contraindication.
Okay, sir. What is the usual dose you use in elderly patients, sir? It is 50 milligram OD or 50 milligram twice a day?
Sir, in elderly patients, most probably, if no contraindication, the patient will be on metformin, sir. So, other than first, we will start with 50 milligram if kidney functions and liver functions and kidney functions are normal. We can start with 50 milligram OD. Then, how the patient is responding, because the treatment should be individualized for every patient. So, we should titrate the dose with seeing the patient's response without any side effects, and how the blood glucose is lowering, and how the patient is responding, what are the side effects. With all these things, we can titrate the dose. First, initially is to start with 50 milligram OD.
Okay. Your point is well taken, sir, because elderly people, even with the DPP4 inhibitors, they can go for hypoglycemia, but it is safer to start with lower dose than up titrate to full dose. And Dr. Joseph, sir, how commonly you find elevations in transaminase levels with the use of vildagliptin? Do you test regularly for the transaminase levels, or just like that with other gliptins, you use it regularly without any testing of LFT?
Yes, I don't think it is not recommended. It's not recommended to monitor LFT because it's not a hepatotoxic drug. But whenever the patient is having hepatic dysfunction, you have to be very careful, because this drug is metabolized in the liver. Otherwise, regularly we used to check LFT periodically in diabetic patients. For example, once in 6 months or annually. I think that would be sufficient. Whenever the patient is showing any symptoms, or the patient is at risk of liver dysfunction, and if the patient is taking hepatotoxic drugs like ATT and other drugs, we can monitor. Otherwise, I don't think it is necessary LFT.
Yeah, you are right, sir. There are no recommendations strictly to do transaminase levels every time you use vildagliptin, because many of the studies have shown that it is safe with respect to liver function. There is no extra elevation of transaminases. Though in few cases, there may be transient elevation of transaminases, and after that it settles down. So they have not recommended for routine testing of transaminases in clinical practice with immediate release preparation. But for once daily preparation, there are no global guidelines because globally this once daily preparation is not available. Only in India they have come out with a once daily preparation. But some of the articles I have read that when you are using once daily preparation, you have to do a transaminase level at least once before starting, and after 3 to 4 weeks after initiation of this once daily preparation. After that, if it is stable, then you can continue without any testing. So, but there are no proper guidelines. Some of the articles have shown these evidences. So, moving on to the next topic, how do you compare vildagliptin with other gliptins? So, how far vildagliptin is superior or equal to other gliptins in your clinical practice? Dr. Joseph, sir.
So I think all the gliptins are most equal in efficacy. So the thing is, it has to be used twice daily. Vildagliptin should be used for to get full effect. So we need to prescribe twice daily. Other gliptins like sitagliptin and this linagliptin all can be given once daily. But regarding the efficacy and glycemic control, I think so almost all are same. All are same. So we are getting the same level of glycemic control in terms of fasting blood sugar reduction, post-mortem reduction, and this HbA1c reduction. I don't find any difference. But we do then only we'll know unless we do head-to-head trial. It's very difficult to comment on that.
Okay.
What's your opinion?
Sir? Yeah. Let me finish, Dr. Sivakumar, sir. Sir, what is your opinion regarding
Yes,
this
sir. As
topic,
sir
sir?
said, the efficacious wise, there is no difference in DPP4 inhibitors, but a lot of studies showing how much amount of percentage of DPP4 enzyme is inhibited.
Yes.
It varies with a lot of gliptins. More with the sitagliptin and more with the linagliptin rather than with the teneligliptin and this vildagliptin. But in clinical practice, sir, I use vildagliptin. I don't use vildagliptin OD preparation. I will use more of BD preparations. That too, along with metformin only. I'm using a lot of vildagliptin with metformin rather than alone with vildagliptin. So I'm not able to say whether the HbA1c reduction is purely with vildagliptin alone or with vildagliptin with metformin. I don't know, because with vildagliptin with the metformin combination once arise, I am easily achieving the target of metformin 2 gram per day rather than achieving the target of vildagliptin 100 milligram per day. I am easily achieving the target of metformin 2 gram per day for almost all patients with vildagliptin 50 milligram BD. So I don't know. I am not able to say at present which gliptin is efficacious as of now, but the amount of DPP4 inhibition is more with the other gliptins when compared with the vildagliptin, I think so, sir.
Yes, sir. You are right, sir. As rightly told by both of you, there are no head-to-head comparison trial between all these agents. But technically speaking, when you go through the pharmacokinetic of sitagliptin and vildagliptin, sitagliptin is one agent which is going to inhibit more than 80% of the DPP4 enzymes present in the patient. So to call it as an effective agent, any gliptin has to inhibit more than 80% of the available DPP4 enzymes. So in that manner, sitagliptin definitely inhibits more than 80%. But when coming to vildagliptin, when you are going to use it as a 50 milligram once daily, it is less than 80 only. The DPP4 inhibition is around 60 to 70% only. But when you use it as a twice daily agent, it is almost on par with sitagliptin. It is more than 80%. So it is as equal as sitagliptin. Vildagliptin twice daily is as equal as sitagliptin once daily preparation when coming to inhibition of this DPP4 enzyme. So efficacy wise, both are equal. But all other gliptins like teneligliptin, saxagliptin, or linagliptin are having less than 70% inhibition of DPP4. But there are other factors which are determining the clinical effect, like as you told, the HbA1c reduction. There are other factors which are going to determine the HbA1c reduction. That is the drugs which we are combining with these agents like metformin or SGLT2 inhibitors. And another way, that is the DPP4 inhibitors are not only going to inhibit the DPP4 enzyme. There are other DPP4 DPP enzyme that like DPP8, DPP9, and FAP. The selectivity is more important. So selective inhibition of DPP4 will be more effective. Like linagliptin has more selectivity towards DPP4 rather than DPP8 and DPP9. So in that manner, linagliptin is also having some positive points towards treatment with treatment for type 2 diabetes patient. So inhibition of this other DPP enzymes like 8, 9, and FAP are going to produce side effects like vascular problems and cardiac failure, which is seen with saxagliptin and alogliptin, are all because of the off-target inhibition of DPP enzymes. So what is your take on this question, sir? Do you find, Dr. Sundar Madhu, sir, do you find any difference between various gliptins in cardiac patients? So though, as I told, we don't have any cardiovascular outcome trial with vildagliptin, and we have outcome trials with all other gliptins. So how do you select the agents in your patients?
DPP, according to the DPP inhibitor, in cardiac patients, sitagliptin is comparatively safer compared to other gliptins. Some tinagliptin has a concern about, we have the concern about the arrhythmia, palpitation, and everything is seen with tinagliptin. And the vildagliptin, as already told, it is definitely not used in acute compensated heart failure patients, class 3, class 4. But if the stable patient, I am using in most of the patients because of the cost effect.
Yes.
Cost effect. Compared to sitagliptin, it is definitely it is a cheaper molecule. So in the stable cardiac patients, we cannot. I am not finding any much worsening or intolerability with vildagliptin. Tinagliptin I am not using because of the arrhythmia risk, and other salts and is not advisable in cardiac patients, in heart failure patients. Whereas stable cardiac patient, stable coronary artery disease patient with a diabetic, other sax and lina may be used. As in cardiac patient, in DTP inhibitor, the first difference is sitagliptin, the second is vildagliptin.
Yes, sir, rightly said. Teneligliptin has the problem with QTC prolongation. So it has been well documented that usage of high dose of teneligliptin, like more than 40 milligram, is going to produce QTC prolongation, and it's going to land up, the patient is going to land up in arrhythmias. Similarly, this QTC study has been done with vildagliptin also. The preliminary studies with the innovator company has undergone all sorts of trials. Vildagliptin with respect to QTC prolongation has been done, and it was found that there was no extra QTC prolongation with the use of vildagliptin. It is safe in all sorts of cardiovascular patients. So that's why FDA has not recommended cardiovascular outcome trial with vildagliptin. So without vildagliptin cardiovascular outcome trial itself, they have labeled that they are cardiovascular safe, except for stage 3 and stage 4 cardiac failure. And moving on to the next topic, do you have any experience with this once daily preparation, sir? Joseph, sir?
So far, no. So I'm yet to use this combination because the innovator brand, they have not recommended any once daily preparation. So till now I am using twice daily preparation.
Yeah, what about you, sir? Dr. Sivakumar, sir?
As I already told, sir, I am not using once daily preparation.
Okay.
I am using only twice daily preparations.
Okay.
And along with metformin only, I am using more rather than plain vildagliptin.
Okay. So recently I have started using this once daily preparation with good efficacy only, but we do baseline liver function test for all patients. So though
In my
there are no
practice, sir,
guidelines, yeah, though there are no clear-cut guidelines for the usage of once daily preparation globally, there are some articles to suggest that it is better to do a baseline LFT for all patients before initiating this 100 milligram OD preparation. So we have started using, and we have not found any abnormal elevation in the transaminases level. What they suggest is there must be more than 3 times elevations of transaminase levels to call it as an adverse event. So far we have not seen such cases. So we have used it for more than 10 to 15 patients, but in the review also we have not found any elevations in the transaminase level. So as of now, it is very safe, my clinical practice, but we need some time, maybe a year or two, to find out whether these effects are persistent or not. So, what is your take on this vildagliptin post-patent? That is, most of the Indian companies are now coming out with vildagliptin molecules at a lower price. Has it changed your way you prescribe DPP-4 inhibitors, Dr. Sukumar sir?
Yes, sir, definitely. Because this post-patent, after this patency has gone, and the vildagliptin price has been reduced, so this DPP4 enzyme inhibition, this there has been this this good thing of inhibiting DPP4 enzyme has been transferred to most patients, because these patients lack these effect only because of cost. We are very, the physician's inertia, we call it as physician's inertia to write these drugs only because of cost. So this that has been gone, and because of such a good drug and such a weight neutral, not having hypoglycemia, and having all other green ticks for this drug, we should give this drug to each and every patient with type 2 diabetes, unless otherwise it is contraindicated. So price was the only problem before patency, because we are not using this drug for a lot of patients. But definitely, I said I am thinking that it is a boon to a lot of patients. After this patency has gone, we are using a lot, and very soon we think we can achieve HbA1c control in lot of patients with this combination and with this vildagliptin.
Yes, sir. Yes, sir. Dr. Joseph, sir, vildagliptin has now come out with a lower price on par with teneligliptin, and even lesser than teneligliptin. Do you still continue use teneligliptin?
Yeah, so still I'm using, but if the patient's under very good control, so if we can continue with the teneligliptin, if the patient does not show any cardiac dysfunction, like so you have to regularly monitor ECG, so to diagnose QTC prolongation. If the patient is if the patient is doing well, I think we can continue. But after the price reduction, so I started writing using more vildagliptin for more number of patients with very good results. If the patient does not show desired reduction, HbA1c reduction, I think we can change it to vildagliptin from teneligliptin. If the patient is doing well, I think we can continue the teneligliptin.
Yes, sir, you are right. Because vildagliptin is a globally accepted molecule with a lot of clinical trials and better benefits in patients with type 2 diabetes without any cardiac adverse events. We can extend the use of vildagliptin to all patients who have not having the privilege to use so far because of the cost, as told by Dr. Sukumar sir. So earlier we were hesitant to start drugs like DPP4 inhibitors because of the cost. Now we have a globally accepted molecule at lower price, so we can extend the use of vildagliptin to almost most of our patients to let them get the benefit of vildagliptin. So I think we have finished all the topics of discussion. So uh, can we end the program with a small summary?
Yes, sir. Thank you, sir. In fact, there was only one question, which is one daily formulation of vildagliptin, so which has already been discussed now.
Yes,
So
yes.
there were almost 39 doctors who attended, wherein this only one query which has come, sir.
Okay,
So
okay.
thank you, sir. In fact, we had covered up all the topics. So it was a very nice interactive discussion, which will be more helpful for all the delegates who participated at today's meeting. So firstly, I'd like to take this opportunity to thank our moderator, Dr. Mahesh Babu, sir, for giving us an opportunity and moderating the panel discussion today. I'm sure like all the delegates will be appreciating the views which has been presented. I'd like to thank all the eminent panelists who has joined us today, Dr. Joseph sir, Sundar Madhu sir, Shivakumar sir, and Sampath Kumar sir, for giving us an opportunity and sharing your clinical views on vildagliptin, which will be more helpful for all the doctors who had joined us. And I'm sure all the doctors, delegates who had participated will be appreciating the views which has been presented by all our panelists. Sir, at this juncture, we like to salute all the doctors and paramedicals who had contributed immensely for keeping us all safe and healthy in these challenging times. Sir, we at Alchem Laboratories will continue to serve doctors and patients by making our products available, especially Glovilda and Glovilda M, Jupiros, and World Cup. Thank you, sir. Thanks once again. Good night, sir. Thanks for this opportunity.
Thank you. Thank you all.
Thank you.
Thank you, sir.
Thank you. Thank you, sir. Thank you. Thank you.
Joseph, sir. Thanks, sir.
Thank you, thank you.
எப்படி சார் இருக்கீங்க?
நல்லா இருக்கேன். எங்க மதுரையில இருக்கீங்களா?
இல்ல சார், நான் கொச்சின்ல இருக்கேன்.
கொச்சின்ல.
நான் ஆக்சுவலா வந்து திருச்சி வந்திருந்தேன். அன்னைக்கு நீங்க லீவ்ல இருந்தீங்க. I could not able to meet last week வந்திருந்தேன் சார்.
Okay. Next time meet பண்ணலாம் definitely.
ஓகேமா சார். Thanks sir.
Right, thank you.
Thank you, sir.